Hi, I'm Dr. Jennifer Robinson. I'm professor in the departments of epidemiology and medicine and director of the Prevention Intervention Center at the University of Iowa in Iowa City. I'm here today to discuss with you the emerging role of PCSK9 inhibition in preventive cardiology, especially for patients at high cardiovascular risk. I will pose critical questions about these novel LDL-lowering agents as a framework for reviewing their mechanisms of action, describing their efficacy, safety, and tolerability profiles, and explaining their place and potential in patients with unmet cardioprotective needs. Please note that at the date of this recording, none of the PCSK9 agents in development has been approved by the FDA, but decisions are pending for 2 of them in the near future. The first question is, what is PCSK9 and why should I want to inhibit it? So let's go through this diagram and first review what regular way that the body removes cholesterol from the body via the LDL particle. And so you can see here the LDL particle binds to the LDL receptor, that's a little red squiggle, and what happens is that LDL receptor complex is then vaginated into the cell, and within the vesicle it then splits off the LDL receptor, which is returned to the cell surface and goes back and starts removing LDL cholesterol from the body, and it actually recycles the LDL receptor up to 150 times. In the meanwhile, the LDL particle actually is broken down and either used within the cell or in the liver is excreted in the bile. But what happens when you have PCSK9 is that PCSK9 binds to the LDL receptor complex, and instead of going through this nice recycling of the LDL receptor, it actually tells the vesicle, break down the LDL and the LDL receptor complex, and so it basically removes LDL receptors from the circulation. And so when we use PCSK9 inhibitors, in this example, monoclonal antibodies, the monoclonal antibody up here in the left-hand corner in the pink binds to the pink, which is the PCSK9, and blocks it from, inhibits it from binding to the LDL receptor complex. And so this nice process can continue. The LDL receptors continue to be recycled and cholesterol removed from the body. So that's a very elegant way of enhancing the body's natural way of taking cholesterol out of the blood. The other thing you might ask is, why do we need a monoclonal antibody? That's pretty high tech. Why can't we just have people take a pill? Well, it turns out that the part of PCSK9 that inactivates it is actually flat, and so the antibody, you can direct it against the flat area to inactivate it, but you really need to have a cleft for a small molecule to inactivate a protein, and so that's why we have monoclonal antibodies right now. And really, people have tried small molecules and they really haven't been effective to date. The other important thing to note about this metabolic process is it turns out that both PCSK9 and LDL receptors are regulated by the same process. It's called SREBP2 in the nucleus. But what happens when intracellular cholesterol levels fall, SREBP2 then tells the body's synthetic system to make both PCSK9 and LDL receptors. So it's interesting that if you lower intracellular cholesterol levels with a statin, you not only increase LDL receptor secretion, but you also increase PCSK9. And so that's why PCSK9 inhibitors work actually about 15% better in the setting of statin therapy, simply because they're blocking this upregulation of PCSK9 excretion by the statin. So we talked about why they're monoclonal antibodies, but let's look next at why would you use monoclonal antibodies to lower to inhibit PCSK9. And this is some pharmacokinetics that we'll kind of walk through here, and really shows the really dynamic relationship between the antibody, PCSK9, and LDL levels. So you can see here in blue, this is LDL, and you can see the levels are high, and you inject at time 0 the monoclonal antibody, and that's in yellow, and you can see the levels rise immediately, and LDL levels just plummet because all those LDL receptors are recycling. And then what happens, PCSK9 levels also plummet, but as the antibody gets consumed, you can see the free PCSK9 levels rise, and so does the LDL receptor, or the LDL level as well, because the LDL receptors are now being removed from the circulation. So this is why we have to give it's a little bit different mechanism of action than, you know, again, small molecules, but this is why we need to give the monoclonal antibodies on a regular schedule. And this is data from alirocumab study in patients with heterozygous FH, but it looks the same in people without heterozygous FH. And here you can see that if you give alirocumab 150 milligrams every 4 weeks, you get this what we call a sawtooth pattern. So the LDL levels plummet at about week 2, but then they start rising as the monoclonal antibody gets used up, and so they're back about halfway to normal at week 4. But if you give 150 milligrams every 2 weeks, you can see in the gold you have a very nice suppression of LDL that's very, very flat. Now you could say, well, does it have any physiologic impact to have your LDL levels going up and down? Probably not over this time period, but on average it will mean that your LDL is lower with a longer treatment duration. So I think it'll be kind of hard to assess what longer treatment, you know, trying to stretch out the treatment duration to try to save patients money. It's going to be kind of hard to figure out what that's doing to their LDL levels. And so the next question is, where are PCSK9 inhibitors in development? And so this next slide is kind of busy with lots of data on it, but basically there are 3 PCSK9 monoclonal antibodies in phase 2 and 3 trials. Alirocumab is the Odyssey program. Evolocumab are the scientists program, and then bococizumab is the Spire program. Alirocumab and evolocumab are fully human antibodies. Bococizumab is humanized, so there's still a little bit of the mouse part of the antibody left, but mostly it's fully human. And part of this has to be apparently there's a lot of science involved in engineering these antibodies, and it's quite complicated. But nonetheless, they're all being evaluated in a broad range of patients, people with heterozygous familial hypercholesterolemia, people in combination with statin therapy or statins combined with other lipid-lowering therapy across all of the programs. They've been evaluated as monotherapy. They've been evaluated in statin-intolerant patients. And they've also been evaluated for efficacy and safety over the long term. And you can see along the bottom are listed the cardiovascular outcomes trials. So most of the trials, just to take a step back a minute, all the Odyssey trials are done. Although some longer-term follow-up is continuing in some of the trials. The evolocumab trials are completed with still some follow-up in the Osler study. The Spire trials are still ongoing. We don't have any results from those phase 3 trials. The other trials that are ongoing are the cardiovascular outcomes trials. Odyssey Outcomes is being performed. It's a placebo-controlled trial in people on maximally treated with statin therapy and acute coronary syndromes, 18,000 patients, and that is on track. I believe it's still recruiting. Fourier is evolocumab versus placebo in people on high-intensity statin therapy with chronic cardiovascular disease plus other high-risk characteristics, 27,000 people, and that one has finished recruiting and ongoing follow-up. And then the Spire 1 and 2, 2 different studies. They have different entry LDL levels. one is 70 to 99 and the other is 100 or over. But again, high cardiovascular risk patients, and they're again all ongoing. The next question is, what is the efficacy? How much do PCSK9 monoclonal antibodies lower LDL, cholesterol, and other lipids and lipoproteins? So first of all, I'm not going to go through all that extensive data from the slide I showed you previously, but just to kind of highlight a few things. First of all, alirocumab, 150 milligrams every 2 weeks, is pretty similar in efficacy to evolocumab, either 140 milligrams every 2 weeks or 420 milligrams every 4 weeks, so threefold higher dose every 4 weeks to kind of combat that sawtoothing effect. And you can see that efficacy is quite similar, about a 62%, 61% reduction in LDL cholesterol versus placebo, 70 milligram per deciliter reductions in LDL, so people are getting average achieved LDLs in these studies for alirocumab going from about 120 down to about 50, with a long duration of efficacy over 78 weeks. And then in Osler, again, quite a dramatic reduction in LDL cholesterol from baseline, again, down into a level of from about 120 to about 50. So very effective drugs. The alirocumab can also be dosed as 75 milligrams every 2 weeks and increased to 150 milligrams every 2 weeks if the LDL remains over 70. And so the efficacy in those studies is a little closer to 55%, 50 to 55% with that titration strategy. The other group of patients it's interesting to look at are those who it's being used as monotherapy. Remember, I alluded to a little greater efficacy when PCSK9 inhibitors are used with a statin. And so probably I would kind of rule of thumb, I'd say about a 50-55% reduction in LDL compared to baseline with the addition of a PCSK9 inhibitor. And you can also see in these monotherapy trials, they compared it to ezetimibe. So ezetimibe lowers LDL about 20%, and you can see that evolocumab and alirocumab are quite a bit more effective in lowering LDL than ezetimibe. The other thing that happens with PCSK9 inhibitors, they're acting by upregulating the LDL receptor, and so of course LDL contains ApoB. Every single one has LDL molecule has an ApoB, and so that level goes down as well. LDL is a large constituent of non-HDL cholesterol, also goes down quite a lot. This is Descartes, evolocumab, 420 every 4 weeks with about a 60% reduction in LDL. The other interesting thing, and I think was surprising with these drugs, is that lipoprotein a goes down about 20 to 25% across all the trials, and whether that will have any cardiovascular effects is unknown, but clearly does differentiate it from ezetimibe and statins with quite a dramatic reduction in lipoprotein A levels. Triglycerides don't go down too much. HDL goes up a little bit. So really the focus is on those apolipoprotein B containing lipoproteins and their reduction. And that's really the causal pathway that we understand best in terms of reducing cardiovascular events. So the next question is do they work in everybody? Does the PCSK9 monoclonal antibodies, do they have similar efficacy across subgroups of patients? And I think the most important group is heterozygous FH versus non-heterozygous FH, and you can see on the left here that compared to placebo, very similar reductions. Even though the heterozygous FH population, has one normal LDL receptor, but the other one is defective, but doesn't make any difference, similar efficacy. This other slide on the right actually shows, it looks like PCSK9 inhibitors have similar efficacy versus baseline across the quartiles of LDL included in the study. In Odyssey long-term, about a 60% reduction. It doesn't matter how high your LDL is from baseline. It's actually kind of interesting. The difference versus placebo is quite variable because there was regression to the mean in the placebo group. across these patients. In terms of other groups of patients that have been evaluated, pretty similar efficacy across all of them. The only group, maybe women in the alirocumab studies, may be slightly less efficacious, but again, quite robust LDL lowering even in women of 55 to 57%. And so again, I don't think there's particularly any concerns regarding efficacy for any patient subgroup. One other patient subgroup that's quite interesting are those with homozygous FH, a uncommon, difficult to treat, untreated LDL levels of 600 or so. Usually they're treated with LDL apheresis and some other drugs. But it's interesting, the PCSK9 inhibitor evolocumab has been tested in patients with heterozygous FH, and evolocumab 420 every 4 weeks lowers LDL about 30%, and the efficacy really is determined by how much LDL functionality, LDL receptor functionality the patient has. Many of these patients, some are have the same defective allele, and many also have a little bit of LDL receptor function, but also quite a few are compound heterozygotes, and so they have varying amounts of LDL receptor function. So the more LDL receptor function, the more efficacious the PCSK9 monoclonal antibodies are. So again, another tool to add to our armamentarium of treating these very high-risk patients. So the next question is, we've got tremendous efficacy, but are they safe? And so let me go through some of that data. This slide shows data from the Odyssey long-term, which was, again, alirocumab 150 every 2 weeks with 78 weeks of treatment and 2 more weeks of follow-up versus placebo. Descartes is evolocumab 420 every 4 weeks versus placebo for 52 weeks versus placebo. And then finally, Osler 1 and 2, they could be on either dosing regimen for evolocumab, depending on their preference, either 420 every 4 weeks or 140 every 2 weeks. And this was compared to standard care over 11 months. And this was only blinded up until week 12. So after that, there was open label follow-up. So in terms of the most common injection site reaction, it's really pretty, relatively uncommon, a little bit preponderance in numerically in the active antibody group versus the placebo injection, but again, not terribly common. Myalgias, again, a little bit of an imbalance, but again, not particularly common. Neurocognitive AEs have been the most concerning for people. Again, uncommon, numerically imbalanced. Little bit of more in the memory category of neurocognitive adverse events, but again, not terribly common and not clinically significant to date. And then in the alirocumab study, a little imbalance in the ophthalmologic AEs. So again, pretty clean profile in really a lot of patients to date for over 1 to 1.5 years of treatment. Now that's not to say that there might not be safety concerns over longer durations of treatment, and that's really why we need to wait for the outcomes trials data to really get the full picture of the net benefit from PCSK9 inhibitors. It's not only the event reduction, but also you have to weigh that against the potential for harm. The other question that comes up, these are injectable monoclonal antibodies. Does the body mount an immune response against them? And so to date, it doesn't really look like it. They really haven't been neutralizing antibodies reported in these long-term trials, although Descartes was the only one that reported them here. Some of the shorter-term trials, it doesn't really look like it. And of course, the data are pending for bococizumab, which is humanized. The other exciting thing is that when we looked at the safety, we also started seeing a signal emerge for a reduction in cardiovascular events as well, which I'll talk about. And it really turns out the event rates are quite similar in both the Odyssey long-term and the Osler trials due to the duration, but you can see about a 50% relative risk reduction in both studies. So I think replication of the results with 2 different antibodies is promising that these are going to have the cardiovascular event reduction benefit that we're looking for. The next question emerges, we've got these powerful drugs for lowering LDL, can we get too low? And so how safe are very low LDL levels from PCSK9 monoclonal antibodies? Probably the best data we have for that in 78 weeks of treatment, 80 weeks of follow-up, over 2,500 people, is from the Odyssey long-term study with alirocumab. And in this trial, about 40% of people had an LDL less than 25 on 2 or more consecutive occasions, and a smaller proportion had an LDL less than 15. And it turned out there was really no meaningful imbalances in adverse events, no excess of musculoskeletal or neurologic events. And we also looked at the some hormones and fat-soluble vitamins, and again, no clinically meaningful differences over 78 weeks of treatment. So again, it's reassuring. The outcomes trials will be getting lots of people down to very low LDL levels, and we'll really need that data to get the full safety picture. But again, reassuring to date. So the next question, do PCSK9 monoclonal antibodies reduce cardiovascular events? And the answer is, well, we have data from preliminary data that they do, and we have 4 cardiovascular outcomes trials ongoing to really establish that. But in the meantime, we do have some, again, promising data that we're on the right track with PCSK9 inhibitors to further lower LDL. This is data from the Odyssey long-term on the left, again, a year and a half of therapy, and from Osler with about 11 months of therapy on the right. And you can see the little insets look identical, about a 50% reduction in events, and the curves diverge almost immediately. So the fact that we've replicated and have very similar results, even in these very preliminary short-term trials, is exciting, and it suggests there might be very interesting things going on acutely other than just modifying the atherosclerotic process itself, but in terms of reducing thrombotic potential. Is it due to LDL-lowering? Some other effect on coagulation factors? You know, it's unknown, but I think, again, it's nice to see this. The other thing that's interesting, people have done meta-analyses now of all of the phase 2 and 3 shorter-term efficacy safety trials, and not only is there a reduction in cardiovascular events, there's a reduction in total mortality due to the reduction in cardiovascular mortality. So again, all of this is very good news that we're on the right track with this new class of drugs. So the last part of the section, I really like to talk about, who can we use, how can we use these drugs clinically to improve patient outcomes. And so, we certainly have groups that were tested in the trials and that we, clearly have an unmet need in terms of people continuing to be at high cardiovascular risk despite statin therapy. So clearly people with familial hypercholesterolemia, people with genetic high cholesterol, familial hypercholesterolemia, they've had high cholesterol levels since birth, definitely great candidates for this drug, and with well-established efficacy. People with clinical cardiovascular disease who are still at high risk despite statin therapy. People who are statin intolerant in these high-risk groups who certainly could benefit from additional LDL lowering. People with diabetes, and probably high-risk primary prevention with a greater than 20% 10-year ASCVD risk would also be potential patients who could benefit from the addition of PCSK9 therapy, or at least from additional LDL lowering. So let's talk a little bit about how, within the context of the 2013 ACC-AHA guidelines, we might think about adding non-statin therapy. When we finished the guidelines, we didn't have Improve-It available. We only had data that statins clearly reduce cardiovascular events, and now we have Improve-It, which shows an incremental cardiovascular risk reduction with the addition of ezetimibe to statin therapy in very high-risk patients. So now we have some evidence, and preliminary evidence from PCSK9, that maybe lowering LDL after statins is going to be beneficial with selected drugs. So how might this fit in? Well, one thing we said in the guidelines is that on average, people in the high-intensity statin trials got about a 50% reduction in LDL. So that meant half the patients got less and half got more. And so let me just show you this picture from these waterfall plots. Well, I've just drawn a nice line here on the 50%, and you can see from Jupiter, rosuvastatin 20, half got more reduction and half got less than 50%. So clearly those who had less would be candidates for the addition of ezetimibe therapy to get a 50% reduction. And on the left is moderate intensity statins, and you see hardly anybody gets a 50% reduction. So that's actually the design of Improve It. So adding ezetimibe to try to get close to a 50% reduction would certainly be a reasonable thing to do. But I'd like to kind of take it beyond that, because when we came out with our guidelines, people ran to their data sets to check out this new paradigm. Was it right, or did it work? And what they found actually is that there is no threshold where cardiovascular risk reduction stops for LDL cholesterol. Let me just show you that in a couple of examples. On the left here is a meta-analysis of statin trials, and they looked at cardiovascular events by achieved LDL level. And you can see that those who got achieved LDLs less than 50 had a 56% reduction in the relative risk of coronary disease, which is almost twice that of those who had achieved, not surprisingly, achieved LDL levels of 150 to 174. But the point is, each progressively lower achieved LDL was a greater relative risk reduction, and it didn't seem to stop. On the right are data from a meta-analysis of the IVUS trials, and they pooled all the high-intensity statin patients, so a Rasuva 40, a atorvastatin 80, and what they looked at was atheroma volume, either percent or total atheroma volume, and it doesn't matter how you look at it. The lower you go on LDL down to 15, the more regression you get. And that line never plateaus. And so the lower you get LDL, it really looks like it's going to be a good thing in terms of really influencing the atherosclerotic process and reducing events. So there's no reason to stop necessarily at 100 or 70, but they're, short of giving this, can't afford to give it to everybody. We probably still need to think a little bit more about who's going to have the most benefit from the added therapy. So let me just kind of show you one way that we might want to look at this, and this is to use data from the cholesterol treatment trialists study, and this is, you've all seen this, I'm sure. So each millimole or 40 milligram per deciliter reduction in LDL lowers cardiovascular events about 20%, and it's just a line. The more you lower LDL, the more reduction you get in cardiovascular events. And you Improve It plots right on that line. And here I plotted the Osler 1 and 2 Odyssey long-term, actually are above the line, although the confidence intervals are wide. And actually, if you plot all the Odyssey, including those where they titrated from 75 up to 100, you still have an effect size and event reduction that is at least as good as what you'd expect from statin therapy. So that being said, we can probably use LDL changes, the magnitude of LDL changes, to figure out who's going to benefit from treatment. And the way you do that is you think about the number needed to treat. And so to get there, you need to think about the risk of your patient. So on the left, the 5-year CVD rate. So 15% 5-year CVD, that was the event rate in the Improve It trial. Overall, probably about 20% would be ACS plus diabetes, 15% would be ACS only, 10% would be chronic coronary disease without diabetes on a statin, 15% would be chronic coronary disease with diabetes on a statin. So you can see that the patient's absolute risk varies even in statin-treated patients. And then what you can do is say, what happens if I add a therapy? So for example, if we add ezetimibe and get a 20% LDL reduction, going from 70 to 54, so those are the mean LDLs in Improve It, you get about a 10% reduction in relative risk. That's plotting on that cholesterol treatment trialist line. And you can see that in a patient with 15% 5-year risk, somebody with chronic coronary disease plus diabetes, acute coronary syndrome plus one high-risk characteristic, The 5-year NNT is about 67, which is, well, it's okay. 50 is kind of the magic number. If presumably in a patient who's going to, doesn't have a lot of comorbidities, are probably going to be treated for 10 years, the NNT is 33, and that's actually pretty good. So it would seem reasonable to add ezetimibe to high-risk patients to take their LDL from 70 to 54. But look what happens, and that's in yellow. So look what happens if you add ezetimibe, taking the LDL from 70 to 54 in somebody with chronic coronary disease, 10% 5-year risk. The NNT is 100, and even over 10 years it's 50. In my mind, that's probably a patient who has a pretty marginal benefit. I may talk with them and see if they even want to take it. I don't want to jeopardize them taking evidence-based therapy like statins. And so this can kind of help us to triage our patients and whether or not we, how aggressive we want to be in terms of LDL lowering. Let me give another example. So somebody with chronic CHD, 10% 5-year risk on a statin. Their LDL is still 125. Maybe they can only tolerate Prava 10. Taking the LDL from 125 down to 100, it's about a 25 milligram per deciliter reduction in LDL and a 15% relative risk reduction. You can see the NNT is 67 over 5 years and 33 over 10 years. So, that's probably a good idea. It's probably good to add something to, ezetimibe adds something to get LDL less than 100 in people with coronary disease across the spectrum. Maybe it's that great to get everybody's LDL less than 70, though. And certainly down less than 50 would be a different question. So in blue, let's look at what happens if we start using a drug like PCSK9 inhibitors that may lower cardiovascular risk by up to 50% or even 35% just to be conservative. And you can see in blue that you start getting numbers needed to treat even in lower risk people, chronic coronary disease, 10% of 20, NNT of 20 over 5 years, 10 over 10 years. And it actually doesn't look too bad even in much lower risk people. So if we have more powerful agents, we may consider treating lower risk people. But again, the cost issues may influence how many patients we can actually afford to treat with this. So the last part, I'd kind of like to go into speculation to try to address that question, because I think the studies of PCSK9 inhibitors that we've done to date, they could change the way we prevent and treat atherosclerosis. So let me just show you a couple paradigms about how that might look. So the first paradigm I think we can think about is called plaque stabilization. So remember that slide where I showed you that people LDLs down to 15 were still having plaque regression? Well, on the way to plaque regression, you get plaque stabilization. And if you stabilize plaque, it is stable. It does not rupture. It does not progress. So if we induce massive plaque stabilization with very aggressive LDL reduction, we may be able to do that over some period of time, 3, 4, 5 years, and then stop, and then maintain people over the long term on maximal statin therapy. LDLs less than 100, they will not get new plaques. And so this would be a new paradigm, kind of like we do for cancer. We don't give people chemo their whole life. We just give it long enough to get the cancer into remission, and then in some cases maintain them on suppressive therapy. So similar model, and actually we can document this. We can when these cardiovascular outcomes trials, we were talking with these sponsors, we really are encouraging them to continue to follow the patients once they have stopped active therapy to really document a legacy effect. And indeed, in the statin trials, we know that once people stop statins, and then they just continue to be follow-up, some crossover, some drop out, they continue to have a legacy effect. The curves remain separated over a period of 10 to 20 years, both in heart protection study, in West of Scotland study, and in the Ascot study. So we have a lot of data that even statin therapy, moderate intensity statin therapy, has a profound effect on inducing plaque stabilization and really resets those patients on a lower risk trajectory. So that's kind of an exciting way to think about it. And, you know, if you're only treating people with an expensive drug for 3 years, yet you have a 10-year NNT of 5, the numbers start looking a lot better in terms of cost effectiveness. And then finally, the last paradigm is kind of a fun one. You know, we called it curing atherosclerosis, and just to get people thinking. But what we're really thinking about here is we have this very powerful LDL lowering tool. We can get LDL levels quite low, and we know from animal data that if you take animals who have early atherosclerosis and you dramatically lower their LDL, you not only regress all of their atherosclerosis, but you normalize the vessel. And so this paradigm actually starts early in the course of atherosclerosis, dramatically lower LDL, completely regress atherosclerosis and normalize the artery. And then people, it's not a lifetime of therapy. It took them 30, 40 years to get some atherosclerosis. And so being a disease of decades, we can actually use that in our favor to really regress therapy and then perhaps engage in intermittent therapy after that, really to suppress atherosclerosis development. And then they start to look like the people who kind of started this story. When we looked at people with genetic loss of function mutations in PCSK9, they had lower lifetime LDL levels and very low rates of cardiovascular disease. So trying to recapitulate some of that epidemiology with drug therapy. And the beauty of it is people don't need a lifetime of therapy, and it's really intermittent therapy. So again, I think an exciting time to have new drugs to help, you know, our high-risk patients, but also an exciting time in terms of expanding the science and really exploring really the last part of the LDL story in trying to prevent cardiovascular disease. Thank you very much.